very much. Now, I think Subhadra has to go to a next session, so I would request Subhadra to come forward and talk on setting up a training program for newborn blindness prevention.
Thank you. So I'll just be talking a little bit about what all goes into the training. I think the inspiration is from our polio control program, which occurred in an era where there was no internet, no cell phones, and still the world got together and we were able to conquer a deadly disease like polio, and it is depicted here how we conquered polio. It was because of the foot soldiers, the health workers, who actually conquered polio. And the development of a two-pronged needle. That means technology with tenderness. That is what on the field helped us to conquer polio, and that is what inspires us, that is how we are going to conquer this severe epidemic of blindness, which is not there at birth. I just want to correct that ROP is not a congenital disease. There is no blindness at birth. It is a postnatal disease. So what we need to do is to develop a lot of human resources to tackle this program. Of course, the ophthalmologist will remain at the forefront of the management, but I think the screening needs to move from ophthalmologists to the health workers on the ground. Then only the large number of children will have access to care and screening, because screening is the crux, but the number of children who need treatment and with improved neonatal care would become less. So the ophthalmologists are not the correct people to actually do all the screening. They should still monitor the screening. So, we need to rope in, and we've already done that, to rope in general ophthalmologists who can do the screening, or the optometrists, the nurses, technician, photographers. So various models can be there. So the good thing I think is that after COVID, everybody has learned to take good photographs, the general people. So you really don't need to train them that what is a good photograph, how to store, how to forward, how to edit, all that they have learned, the technological part. So we just need to train them how to do good photography of the retina. And in addition to that, the program doesn't end there. You need to have a whole army of people who are going to then follow up these patients for their refractive error, their optical glasses, their rehabilitation, low vision, and of course the neonatal anesthesiologist, which used to be a rarity in ophthalmic hospitals, and it was a big struggle to get them to come and operate our 900-gram baby or 1100-gram baby, and still it's a struggle for many doctors where the pediatric neonatologist, anesthetists are not willing to come to an eye hospital, or the eye hospital is not willing to take that risk of taking care of these babies. So that will remain. So there are various education programs you already heard, like CMEs, short-term hands-on courses, which can lay from 2 weeks to 3 months depending on what the candidate wants to learn. We have been running a very successful 1-month hands-on training course. There are others who have different courses. We now have surgical courses for 3 months. So depending on the pre-existing skills, I think the candidates who come for training should be very clear what all they know, what all they don't know, what they want to learn, so that their time is optimized along with their mentor. And of course, the curriculum should be very thorough. When the candidates come to a center for training, it's the duty of the mentors to have the curriculum, the lectures, brochures, give all the pamphlets, all the PPTs to your students, so that they can really make best of it. And we've made it a mandatory rule that in our institute there's no copyright on the posters, on the pamphlets, on the slides. I mean, anybody, they're available on the net also, YouTube also. You can just take them. Please use them for your babies. Then we need to teach them the clinical methods, and in clinical methods, just not look at the retina, but how to carefully handle that baby, make talk with that baby, talk to the parents. It's a very stressful situation for the baby and parents. So part of counseling and caring for that baby with your heart and hands and head becomes very important in this situation. Then how to handle the diagnostic equipments, whether it is photography, different types of photographic machines now available. Then the surgical trainings, which we go through simulators, wet lab, and assisting the surgeries and picking up surgeries. And then the art of patient care, how to manage difficult situations, failed surgeries, apnea, deaths. So many things will happen. So we should have a coordinated team and program how we are going to handle that. So during the training, we train the trainees how to handle all these difficult situations, because everything may not turn out well. Then the social, economical, surveillance, administrative aspects, because you will come up with barriers with the government, with the RBSK team. So you have to really learn how to tackle all those situations, because if you are going to go into the public. So the bedside training is very essential. So from beginning we feel that the program should be in the NICU, it should be NICU based, and that is where the whole thing should happen. And slowly the onus of screening and getting those babies should be handed over to the NICU. So now with the cameras, we are now training the nurses and the technicians of the NICU itself, and they should take over the screening, just like they have taken over the screening of cardiac defects. They don't call cardiologists to do the 2D echo now. They do the 2D echo. Once they detect a problem, they call in the cardiologist. So they should be doing the screening and doing the photography and learning how to interpret these images and call us only if treatment is required. And during the training, the manpower, whichever is there, they should have a whole team so that they can set up the program. If you just train the fellow and then they don't have a setup and the other team members are not trained, then they cannot function. They cannot function in isolation. So training of whole team. And while we do the training, there should also be an evaluation of your training system with feedbacks and trying to improve, and then once they go, there should be an exit evaluation. What are the competencies, whether they can do, not do, where do they need further training or further refinement, and that hand holding when they go back to their place. Now with the imaging system, you can send the images, you can call us, we can counsel, and we can, guide you. So that works. Of course, today I think nobody should say that we are not able to do a fundus photograph. So many tools are available, small ones with your smartphone, and adult cameras and pediatric cameras. So we should try to image, we should try to take pictures, when you're asking for second opinion or something. So there are so many cameras there, and then, we can follow them. If you take pictures, then you can follow them up much better than if you cannot. And the last but not the least, to take good care. The candidate should be so well trained, like Viju Raju, who can treat their own child. Within a month of finishing his fellowship, he was able to take care of his own one disease. So that's the level of competency we want at the end of a good training program, hand-holding, treating, and building the whole team for the city or the town or the NICU. So that whole program should be brought to forth for the whole team, and then it really helps. So I think there are still gaps in the curriculum. We can't keep on doing this firefighting for decades. We are already doing it for 30 years. But I think the baseline, when the curriculum is being developed for the DNB candidates, for the MS candidates, fortunately in ophthalmology it has come, but still they don't have practical exposure, but at least the sensitivity, but it should come in the DNB of the pediatricians also. So I think I'm most happy with all these fellows. They are pioneers of change. Once they train, they set up their own program, and then they train more, and that is what we should encourage. So I trained 2 people from Bangladesh. I got 20 applications. Please train us. I said, no. Now you train with them, and once they train you, then you can come back for a 1 week polishing with me. So that way we could train 20, 30 people there within a manner of 2 years. So I think these students, once they get trained, they, lead us more further. They have more innovative ways. They are better than us. And this is Samarth Agarwal, who, put up these posters on his car, which I never thought in 20 years. So, when you train people, they really take your program forward and give you great joy. So let's go. Thank you. So I have to go, but I'll try to come back.
Thank you very much, Subhadra, for a very short suite. I was expecting more from you, but I believe you are very busy. So maybe next time, no problem.